Welcome to another Puscast, the first one of 2017. I think I've been doing these since like 2005, 2006. So I'm an old man in the world of podcasting. Hell, I'm just an old man. And if you're not yet sick of me after all this time, let me point out that there's an interview with me over at the show Mythwits, MWTHWITS, where I ramble on about a bunch of infectious disease and alternative medicine stuff, and then end up being humiliated in a game of Jeopardy. Must-see TV, more like musty TV. Otherwise, not much to say, blah, 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 as I always say at the beginning of the podcast. So let's move on to the literature, shall we? I have said before that one of the articles that gave me my cognitive framework for understanding infectious diseases was way back in 1989 in the American Journal of Medicine, where they published the article Observations on Spiraling Empiricisms, Its Causes, Allure, and Perils, with particular reference to antibiotic therapy. Everyone should read this article, along with Makoviak's article in JAMA on what constitutes normal body temperature. And now I think I would add from JAMA the article Rethinking How Antibiotics Are Prescribed, Incorporating the 4 Moments of Antibiotic Decision Making into Clinical Practice. I really like the article, and I think it's an interesting and important conceptual framework to consider when prescribing antibiotics. What, might you ask, are those 4 moments of antibiotic decision making? Well, the first, of course, is, does the patient have an infection that requires antibiotics? Be surprised how often the answer is no. Moment 2, have I ordered appropriate cultures before starting antibiotics? What empirical antibiotics should I initiate? Moment 3, a day or more has passed. Can I stop antibiotics? Probably. Can I narrow therapy? Probably. Can I change from intravenous to oral therapy? Probably. And finally, the 4th moment, what duration of antibiotic therapy is needed for this patient's diagnosis? So often when I do antibiotic stewardship, all the above are answered incorrectly. I would suggest that you dig this article up, photocopy it, and tape it to every workroom and on every computer in every hospital in your system. It is most excellent. Now, if you go to Chevy, Chevy's going to tell you they make the best cars. I drive a Chevy Volt. I think it's a wonderful car. Too bad they're not making them anymore. But what if a bunch of ID doctors look into the benefits of an infectious disease consultation? Go to Midas, get a muffler, I suppose. But the results of this article are consistent with all the other articles of a similar vein. Quote, early intervention with an ID physician was associated with lower mortality rate and shorter length of stay. Patients who received an early ID intervention during their hospital stay were less likely to be readmitted after discharge and had lower total healthcare spending. This gets to my belief that no one would manage a cancer without an oncologist or dialysis without, say, a nephrologist. And for many of the complex infectious diseases may benefit from an infectious disease consultation. That being said, I work with a lot of really bright hospitalists, and all too often I'm not really needed. They watch what I do and then repeat it. But still, if you want your infection treated right, call an ID doctor. And you want to get a good car, get a Chevy. Sometimes I'm asked if I'm the IND doctor, and I say, no, that's the surgeon. I'm the ID doctor. And sometimes people call me the bug doctor. And sometimes I wish I was. I don't know if you've been reading about the total collapse of insect populations in the world, but when important pollinators and a major part of the food chain disappears, that's a little worrisome. And I'd like to be a bug doctor to improve the health of the insects. They're, of course, blaming climate change and global warming. There's any number of shitstorms that are going to happen as the world warms, and one of them is infectious diseases. Here's another article that looked at the association, and association is not causation, between temperature, rainfall, and humidity and a variety of infectious diseases in Bangladesh. And many infections were associated with the weather. Humidity, as it went up, was associated with malaria and diarrhea, but as it went up, a decrease in meningitis and encephalitis. Meningitis and encephalitis tended to occur during times of low rainfall, whereas diarrhea, malaria, and enteric fever with increased rainfall. So as the climate changes, you can expect a change in the epidemiology of a variety of infections, but fortunately, all the insect vectors will be dead and no longer pollinating our plants. Yay! But it was noted to me recently that the ICU has seen more than its average Legionella cases in the last couple months. And as a rule, Oregon is not a Legionella place. It's not warm enough or humid enough. But maybe that's changing. I have never seen a case of rabies outside of Tequila Mockingbird. The MMWR mentions a case of rabies of a person who got bit by a puppy in India, did not get post-exposure prophylaxis, came to the United States and died of rabies. As a reminder, rabies is still endemic in 122 countries, and the CDC notes that 9 people have died rabies after being bit overseas. And it turns out, quote, India has the world's largest incidence of dog-mediated human rabies deaths. Here on the West Coast, we have a lot of people from the continent of India. Or is it a subcontinent? Anyway, we have a significant Indian population on the West Coast, and they travel back and forth to visit family members, so it's something to keep in the back of your mind. Or preferably with prophylaxis, it never enters your mind. A rabies prophylaxis joke. And a note about Zika virus from Open Forum Infectious Diseases. They looked at patients with Zika virus who had severe thrombocytopenia, and this was associated with increased morbidity. And it would appear from very small numbers that the treatment is like ITP with IVIG. Patients who received platelet transfusions did not get a bump in their platelets, whilst those who got IVIG, a whopping 5 patients, bumped their platelets up into the 120s. So, little pearl, Zika virus-associated thrombocytopenia, treat it like ITP. With these respiratory panels, we get the diagnosis of pneumonia more often than we used to. And often the question is, what do we make of virus X in the panel? This one looked at how patients did with parainfluenza virus positivity, and they were all quite sick. Now, it's a biased population because these are people who were hospitalized for pneumonia, but they averaged 7.7 days in the hospital with the usual URI symptoms, cough, fever, dyspnea, fatigue, etc. One pearl is that unlike influenza, which with H1N1 often had an underlying bacterial superinfection, this was not the case with parainfluenza, where of the 349 patients who were on antibiotics, none had a confirmed bacterial infection. That's none. Not that that's going to stop anybody from giving antibiotics. People order the panel and then, they don't react to it. 3 AIDS studies. One looked at outcomes in patients with cryptococcal meningitis and found an association with patients who had higher white counts and subsequent mortality. And the cutoff was 3,500 cells in the peripheral blood. It was a study out of Uganda, so I don't know how widely applicable it is given the disparities in the healthcare systems, and it's retrospective. I recently read an interesting article. I wish I saved it from my feeds on how whenever you look at retrospective data, you will always find a pattern. So as always, any retrospective study that finds an association should probably be looked at as a hypothesis generating study rather than a hypothesis proving study. And then a study out of the NIH that nobody in practice will ever be able to use. Their hypothesis was that people who would go on to develop immune reconstitution syndrome would have increased metabolism in, say, the lymph nodes, and they'd have a positive PET scan. So they had 30 HIV patients with CD4 counts under 100, and they did 2 PET scans on them, one before antiretroviral therapy and one 4 to 6 weeks in, and found that those who went on to develop IRIS all had increased metabolic on PET scan prior to the initiation of their ART, which is interesting. Also, this will be a study that I'll never be able to use because I can't get a damn PET scan approved. They cost about 10 grand. So they did 30 PET CTs, that's 300,000. They did it twice, that's 600,000. It's nice to generate data that's of no clinical utility to anybody in the world, except maybe the Netherlands, where they seem to be able to get PET scans with impunity. One always likes to know the source of infectious diseases. What are the risks? This study went and found 24 coyotes, 1 fox, 2 raccoons, a rodent in Texas, and they looked at them for the presence of Borrelia turriticale, which is a cause of tick-borne fever, and they found positive serologies in all of the above. It would suggest that wild dogs and rodents are a source, or at least a reservoir, for relapsing fever in Texas. A nice review of Whipple's endocarditis in open access infectious diseases. The take-homes from this is that aortic valve is the most commonly involved, but 25% would have multiple valves involved. The other interesting thing about this disease is more often than not, they don't have fever, they don't have peripheral stigmata, and inflammatory parameters such as CRP can be normal. Mortality rates are also high at 25%. And then Captain Obvious jumps in with the kind of conclusion that I think should be outlawed in all journals. Quote, clinicians should consider the diagnosis of Whipple's endocarditis in culture-negative endocarditis. Really? It's a cause of culture-negative endocarditis? I'm shocked. And then they say, clinician awareness remains the cornerstone for identification and initiation of appropriate treatment. Well, big duh. I mean, no paper should end with, you need to know what you're doing to know what you're doing. Just like when somebody has a rare report and they say, now you need to consider this unusual organism in your differential diagnosis. No, I don't. Common things are common. That makes for practical medicine. But still, it's an interesting review. And another study on Whipple's suggests that if you have a patient with unexplained intermittent seronegative polyarthritis, including those without constitutional symptoms, you should test for Whipple's. And they did a PCR on the saliva, the stool, and joint fluid. They found Whipple's in about 5% of those patients. But of course, physician awareness is paramount to making the diagnosis, yes. I had always been told, I should probably look this up, that the only sporting statistic that has not changed over time has been free throw shooting percentage, and it's been rock stable pretty much forever. And now similarly, that would apply to 30-day mortality for pneumococcal pneumonia. This study out of Barcelona looked at pneumococcal pneumonia mortality over a 20-year period from 1997 moving forward, and found that despite our vaunted medical care, mortality rates have basically been the same. I find that pretty amazing. And it would suggest it hasn't been the choice in antibiotics that's made the difference, since different antibiotics have been used for pneumococcal pneumonia over that time frame. What's the best therapy for intra-abdominal abscesses? Should you treat enterococcus? Inquiring minds want to know. If you think back to the bad old days, people got put on Gent and Clenda for their intra-abdominal abscess and did fine for the most part as long as they had good source control. The secret is good source control, but physicians and ID doctors have wrung their hands over the years to asking the question, do we need to worry about the enterococcus under those circumstances? And there's data both for and against worrying about the enterococcus and intra-abdominal abscesses. This retrospective, therefore, who knows, study looked at those who got ertapenem versus those who got piptazo for intra-abdominal abscesses that grew epicalis and found the same outcome. So in this particular study, treating the enterococcus didn't matter, which is interesting. However, they were all considered to have adequate source control. And if you do that, it probably doesn't matter what antibiotics you give most of the patients. Me, I tend not to worry over much about the enterococcus in patients who are doing well with good drainage of their abscess. I love a review of the literature that completely validates my bias. It concerns whether or not you need to treat osteomyelitis in sacral pressure ulcers. And they point out that if you don't do debridement and wound coverage, antibiotics are a waste of time. Yes. They point out that MRIs are unreliable and inaccurate because they can't determine the difference between bone remodeling and infections. Yes. And they emphasize that you need to make the diagnosis on bone biopsy and culture. Yes. And they could find no benefit from prolonged antibiotics, i.e. greater than 6 weeks, and suggest even 2 weeks is enough if it's only in the cortical bone. You can bet I'm going to put this review in many a chart note moving forward. It's amazing how often people want to treat without doing biopsies and debridement. If you look it up in the Oxford English Dictionary, you will find that as one definition for futile. Or maybe it's stupid. And there's a study that compared dalbavancin, 2 doses, versus the standard 4 to 6 weeks of antibiotics in osteomyelitis. It was a study done in the Ukraine. Everybody got debridement of their osteomyelitis, and it was mostly gram-positive. And at 3 weeks, 6 months, and 1 year, the outcomes were the same. Dalbavancin, unfortunately, costs an arm and a leg. The big question, which I can't find when I read the study, it all gets down to the key word debridement. My problem is not treating osteomyelitis where all the bone has been removed. My problem is treating osteomyelitis where I can't remove all the infected bone. I think in treating osteo, we often don't differentiate between those that are cured in the OR versus those that require long-term medications to be cured. So I don't know what to make of this study. If both groups had good debridement, then both groups were cured even before they got antibiotics. Back in the Middle Ages, they did not take prisoners. They had somebody who walked the fields and slit the throats of the wounded. That, I think, is often the role of antibiotics in things such as intra-abdominal abscesses and osteomyelitis. If I see a 95+% cure rate in osteomyelitis, I assume the surgeon got it all. So I can't tell. The real question is this show the equivalency of 2 antibiotics in the treatment of osteomyelitis, or does it show that 2 antibiotics are equally good when neither are actually required? I suppose, though, that when the drug rep puts this particular paper on physicians' desks, they don't think about osteomyelitis quite that way, and will get all excited about the way expensive dalbavancin. Sometimes I feel like I'm reporting magic rather than infectious diseases. This study looked at 7,099 Staph aureus genomes and found rifampin-associated alleles that predicted rifampin resistance. They also found that resistance to vancomycin and daptomycin was due to rifampin exposure. How they came to this conclusion is way outside of my lane of understanding. They used some, quote, large-scale evolutionary convergence analysis, end quote. Yeah, like I understand what this stuff is. The bottom line, though, is that worldwide use of rifampin has also been driving resistance not only to rifampin, but vancomycin and daptomycin due to selection of the RPOB gene. It's like when I read the magazine Science every week. I understand the concepts and the conclusions, but I'll be damned if I can understand the actual study that went into it. As Arthur C. Clarke pointed out in his third law, any sufficiently advanced technology is indistinguishable from magic. It sure seems that way to me a lot of the time. So if you have a CRE, a carbapenem-resistant Enterobacteriaceae, and doesn't that sound like a Harry Potter spell? If you have a stable patient with a urinary tract infection and it's one of the rare organisms that is susceptible to TMP sulfa, the TMP sulfa will work just fine, according to this retrospective study cleverly called the CRACKLE, Consortium of Resistance Against Carbapenems and Klebsiella and Other Enterobacteriaceae. I still prefer the Nestle's Crunch knockoff, but what are you going to do? If it's susceptible, it'll work. I've always thought that the data to support the use of antibiotics as a prophylaxis for endocarditis were fairly scanty. Probably not so much on the basis of this study. So in 2007, as you probably know, endocarditis prophylaxis became simpler, and the American Heart Association suggested you no longer need to give antibiotics for patients at moderate risk for endocarditis, but continue antibiotic prophylaxis for those at high risk. So what happened? This study mined the data of patients looking for the results of declining antibiotic prophylaxis orders. And what happens is it fell, obviously, for moderate risk individuals. But interestingly, antibiotic prescriptions also fell for patients at high risk for endocarditis. They shouldn't have done that. And then endocarditis rates started creeping up, not only in the high risk group, which you would expect since they were, high risk, but the high risk group had a 177% increase. The moderate risk group went up as well, a barely significant, they said, 75%. Now, of course, you can't prove causality, and it's always been difficult to prove that prophylactic antibiotics are effective for the prevention of endocarditis and the various underlying cardiac abnormalities for which it is recommended. But this would be strongly suggestive that perhaps antibiotic prophylaxis should go back to the old days, and that those at moderate risk should also get antibiotic prophylaxis. The guidelines include MRSA coverage for patients with nosocomial pneumonia. However, I've always been of the opinion if you don't grow MRSA, it just ain't there. And the studies would show that if you have a negative nasal swab for MRSA, the negative predictive value is about 99%. So they looked at the outcomes of patients who had culture-negative nosocomial pneumonia in whom the vancomycin or other anti-MRSA drugs were stopped. And they found that it did not affect 28-day mortality, but it did lower the hospital length of stay and lowered the incidence of acute kidney injury. So if they're culture negative for MRSA, if their swab is negative for MRSA, stop the vancomycin. You won't hurt the patient by stopping the vanco, but you will certainly hurt the patient by continuing it. I also feel that way, by the way, about Pseudomonas and other evil bugs like Serratia. If you don't grow them, they're not there. If you've ever looked at black tar heroin, you'd be surprised that anybody would shoot that up. It is grody looking stuff. I remember seeing one picture that I think had a banana peel in it. And as I've discussed in the past, if you culture heroin, it is a rich microbiologic stew. I refuse to say it's contaminated because it's not as if they're trying to produce this stuff under sterile technique. Clostridium species are not uncommon in heroin, including Clostridium botulinum. And there was an outbreak of wound botulism last year in San Diego County that affected 9 people, 7 of whom used black tar heroin, and 6 of whom used subcutaneous injections. Perfringens, septicum, and botulinum, and tetanus all can be found in heroin and occasionally in the patients who use it. Having chickens in your backyard is evidently a thing. I wouldn't mind actually having chickens, although in my neighborhood they'd probably be eaten by coyotes or possums, but you get some fresh eggs and the occasional stewed chicken, and they can rid your yard of slugs. But they also carry salmonella. And the CDC, and if I read this right, has said that since 2000, there have been 70 salmonella outbreaks associated with backyard chickens, with 4,794 cases of salmonella. In this case, they traced it back to the mail order chicken supply company that not only supplied people with chickens, but with Salmonella typhimurium. Just another neat little way to get an infectious disease. I don't keep up in my chemotherapeutic agents. Whenever I get a chemo patient, I always PubMed whatever their drugs are with infectious diseases. There's a drug called bendamustine. It's a nitrogen mustard-based chemotherapeutic agent that is often used outside its labeled indication, and they use it for follicular lymphoma and other low-grade lymphomas. It also increases the risk of infections, not only of bacterial infections, according to this review, but CMV, zoster, histoplasmosis, and PJP. So keep it in mind, not only for the differential diagnosis of patients with non-Hodgkin's lymphoma on this medication, but perhaps consideration for infectious prophylaxis in these patients. A couple of mold-related papers. One, they linked the Aspergillus infections in patients to the environmental Aspergillus that was kicked up during major demolition work. That is a well-known problem, and here's another example. But there's also a new blastomyces found in the western United States and Canada, Blastomyces helicus. It used to be called Emmonsia, Emmonsia helica, but Emmonsia has now been changed its name to emergimonas because it's an emerging infection, and I can't tell you how much that name annoys me. What's different about this particular blastomyces, it causes both pneumonia and disseminated disease in primarily immunocompromised patients. In this series, they report 10 human and 5 veterinary cases, all from the Western Canada and United States. And also, by the way, outside the range of classical Blastomyces dermatitidis. Treatment is probably amphotericin up front, followed by one of the newer azoles. There is a hint from exposures that perhaps the source in the environment is prairie dog burrows, but that's based on scant information. So if you see blastomyces outside of blastomyces typical range, think of Blastomyces helicus. And finally, a study out of Uganda that looked at risk of malaria. And interestingly, it was people who traveled around the country who were at higher risk for developing malaria. Probably because if you're out and about, you might be exposed to mosquitoes you might not otherwise be if you stay at home. Of course, what do tourists do? They travel. And so the very act of being a tourist perhaps would increase your risk of malaria. Although I must say, this study looked at Ugandans who traveled, not tourists who traveled. And I think that's it. Regular listeners know I have an affinity for the cardiovascular complications of infectious diseases. There's a nice review in the New England Journal of Medicine about the risk of myocardial infarction and acute infections, warning you not to blow it all off as a troponin leak, whatever the hell that is. And with that, I will bring this Puscast to a close. Don't forget to listen to me on MythWits, if you can tolerate me anymore. To buy my books, I think I mentioned Puss Whisperer 3 is now out, and I'm actually working on a Puss Whisperer 4, because the world needs more Mark Crislip. Otherwise, references are available at edgydoc.com, the home of my multimedia empire. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, take it away, Jeff.